Okay, thank you. So it's my great pleasure to introduce my friend and colleague, Dr. Bruce Rollman, to Cardiology Grand Rounds. Dr. Rollman is the University of Pittsburgh Medical Center Endowed Professor of General Internal Medicine and Professor of Psychiatry, Health Policy and Management, Clinical and Translational Science, and Biomedical Informatics in the Division of General Internal Medicine. He's the founding director of the Center for Behavioral Health and Smart Technology and the Center for Behavioral Health Media and Technology, the goals of which are to link faculty from across Pittsburgh's Schools of Health Sciences and the Medical Center, Carnegie Mellon University, and the local entrepreneurial community to promote new collaborations and to support the next generation of innovators who will create, test, and disseminate scalable solutions for some of the most common, challenging, and costly behavioral health problems. This also provides an academic home for talented new and junior faculty. He received his bachelor's degree in biology from the University of Pennsylvania and went on to receive his degree in medicine from Jefferson Medical College. He did a master's of public health and epidemiology in Johns Hopkins University, and at University of Maryland, Baltimore County, did his internship and residency with a fellowship in general internal medicine at Johns Hopkins. He's a fellow of the Academy of Behavioral Medicine Research and the American College of Physicians, and has served as the president of the American Psychosomatic Society, among many other honors. He has over 100 peer-reviewed publications, among them reports of the several NIH-funded randomized clinical trials testing the collaborative care model for addressing psychosocial multimorbidity in cardiac and related populations. His current research also includes a focus on the use of mobile technologies to reach underserved rural medical populations. I welcome Dr. Rollman to Cardiology Grand Rounds.
Thank you, Dr. Berg and Dr. Velasquez, for inviting me to Yale to present our research here from the University of Pittsburgh. And also, when putting my talk together, I was impressed by how many Yale faculty are involved, and I'll be presenting some of their work as well in my presentation this morning. I have no disclosures. I'm here for hire. So I have no disclosures over here, no speaker bureaus, honorary, et cetera. All the work that I'll show you has been NIH funded. The goals of our presentation are really to raise awareness of the prevalence of impact of depression on patients with cardiovascular disease, describe the collaborative care model or chronic care model that for treating depression that we've been using in Pittsburgh and in other places, and also to present key findings from trials to treat depression in patients with cardiovascular disease. So, as many people in the room know and watching it in their offices or at home, cardiovascular disease is the single leading cause of premature morbidity and mortality in the United States. When I give this talk each year, I try to update my slides from the Heart and Stroke Statistical Update. These costs are only rising. Probably the only thing dropping are the number of MIs and bypass surgeries, but the other heart failure, deaths, all these other numbers, unfortunately, continue to trend up. Depression and cardiovascular disease, however, is very common in the two. Depression is often comorbid with patients with cardiovascular disease. And depending on how you measure the depression, whether it's with a formal interview or using a screening questionnaire like the PHQ, up to half of patients with cardiovascular disease have comorbid depression or elevated mood symptoms. And when it's present, as I'll show you in data, it roughly doubles the risk of mortality, reduces health-related quality of life, and unfortunately, although there are available a variety of safe and effective treatments, often goes unrecognized and untreated by cardiologists, primary care physicians, and other clinicians. So there was a landmark article that came out, wow, it's been like 14 years ago, advising routine depression screening for patients who are post-MI, post-bypass surgery, and those with angina. I don't know how many people in this room are familiar with this that came out. Most of the time when I present this, people say that they had never heard of this report before, but we'll be going back to this. But this is something, some cardiologists and researchers Matt had mentioned American Psychosomatic Society. There are a number of people who are co-authors of this paper who are very involved with the society, but my role here coming to Yale is kind of introduce a topic to people who may be less familiar. This is one of my favorite quotes by Louis Pasteur about chance favoring the prepared mind. And by the time I came to the University of Pittsburgh from Johns Hopkins out of my fellowship on a practice interview, at the time, my research interest had been on adherence with healthcare recommendations and medications in particular. But it was really through mentorship at the university, and specifically in people in our department of psychiatry, that I became interested in depression and its impact on reducing patients' adherence with medications and other recommended care. And between 1995 and 1998, I started getting involved in the field of depression in primary care. And one day I saw an article in the Pittsburgh Post-Gazette that women did not do as well after bypass surgery as men. And authors had speculated maybe it was because women had smaller blood vessels, et cetera, et cetera. And there was this article that came out from the Society of Thoracic Surgeons, looking at a large registry, over 340,000 cases. And they were looking at things like cross-clamp time and ejection fraction and all sorts of other characteristics. But there was nothing in there about depression. And I had a conversation with one of my mentors at Pitt, and I said to this fellow, I wonder if it was because of depression that women did worse after bypass surgery. And by this time, the chance favors the prepared mind. By this time, I was aware that women suffered depression and other affective disorders, anxiety, and so on, at roughly twice the rate as men. But the authors had not done anything. There was nothing in the data set. In the SDS was not collecting information on depression. And so one of my mentors, Dr. Chip Reynolds in psychiatry, had suggested I look into the issue. And then I became obsessed with it. And I found all sorts of really interesting papers that got me turned on to the field. This is a classic paper by Dr. Nancy Fraser Smith. It's probably been cited about 3,500 times in the literature. And I call it the paper, the paper of depression and heart disease. Dr. Fraser Smith, in it, she did something really very simple. Basically, they surveyed people who survived acute MI at the Montreal Heart Institute with formal, at the time, DSM-3 criteria, and to see who had formerly had major depression versus who was not. And what they found, 16% of the group overall had met criteria for major depression, but in 6 months after survival of the acute MI, 17% of those patients were dead, compared to just 3% of the people who were not depressed. And Dr. Fraser Smith and colleagues adjusted for a whole variety of characteristics, that are kind of routine now in cardiovascular medicine, like smoking status, ejection fraction, gender, et cetera, et cetera. And there are only 3 things that still held out in the adjusted multivariate, and that was still major depression. That was still roughly, you were 4 times more likely, more than 4 times more likely to die if you had comorbid major depression following an MI. But you look at this difference over here, 17 and 3%, 14%. So as a young now assistant professor, I was thinking about this. Wow, if we can cut that 14% in half to 7, that would be really big. And I thought about, maybe if we could just tackle one disease, and this was it. I mean, this was amazing. These curves in the 1990s reminded me of like cancer curves, the HIV epidemic, before antiretrovirals and so on. It was huge in my mind. And it wasn't just post-MI. I mean, here's other work too by Francois L'Esperance and Dr. Fraser Smith at Montreal, looking at Beck depression inventory scores and mortality following MI. I mean, these curves reminded me of what you see like in cholesterol and survival. The higher the cholesterol level or LDL cholesterol or whatever, the lower the survival that you see, or the higher the blood pressure. This was a dose response, even at subclinical levels of depression. Here we see this in Ingrid Connery's work after bypass surgery. Same kind of thing. If you're depressed, you're more likely to die, even after adjustment. Here's work from Wei Zhang at Duke. Same idea in heart failure. So across a variety of different, we can go on and on with papers like this, but across a variety of cardiac conditions, the more the presence of depression and the worse of depression, the lower the survival. This is work that we did here at the University of Pittsburgh Medical Center, or UPMC, where we screen people. I'll show you after with the PHQ-2. It's just a 2-item questionnaire that's easy. If you can remember the CAGE questionnaire to screen for alcoholism, it's easy to remember. This is even easier. It's only 2 items. And basically, if a patient said yes to one of the 2 items, these are patients with systolic heart failure or HREF. And if you screen positive, 20% of those people were dead in a year compared to just 8%. So this wasn't just happening in Montreal and at Duke and other places. This was happening here in Pittsburgh. Even after multivariate, as I'll show you too here, it was still a significantly elevated risk of mortality from just those 2 simple questionnaires. Unfortunately, you can't patent the PHQ-2. Kurt Kroenke, who developed it, really it reminded me of Jonas Salk, making it free and available for anyone to use. Or how Dr. Salk said, how can you patent the sun? And Dr. Kroenke is kind of a similar mindset. So this is basically, we'll talk about this in a moment, things that you could do here in New Haven in terms of the screening. So there are a couple of Yale investigators who were involved in this work too. This was a review article that recently came out in circulation and looking at depression, and the effect estimates come from meta-analyses, the citations over here. But again, using more modern techniques, multivariate techniques, and so on, the association between depression and incident, MI, CHD, stroke, obesity, et cetera, is all there. So it's extremely, extremely important. Unfortunately, I can only scratch the surface of the field today, but I hope that there'll be a few people after the talk who might want to research the topic on their own and consider treatments, maybe new ones that haven't been developed or ones that are available, like cardiac rehab, as a way of tackling affective disorders and improving quality of life and survival. Allison Gaffey, I had the pleasure of meeting her for dinner last night here at Yale, also has been working in this area too, and showing the same thing with psychologic distress, increasing cardiovascular morbidity and mortality. So I guess the bumper sticker, as we'd say, is depression kills. If you had to put this on the bumper sticker of your car, on your door, or a button, depression kills. How it kills still yet is up for debate. This is a review article that was in JACC a few years ago. There are a variety of both biologic mechanisms and also behavioral mediators by which depression might affect mortality. So like I mentioned before, we know that people who are depressed are less likely to take their medications, or less likely to quit smoking or make other needed behavioral changes. There's been a variety of work also to show that people who are depressed have stickier platelets, they have autonomic dysfunction, higher blood pressure on average, so more inflammatory cytokines and so on. So there may be a variety of mechanisms by which depression affects morbidity and mortality. Probably no single one, which is probably we'll talk about this later, why we haven't yet seen like depression treatment reducing mortality. But it may, but maybe some people here in this room or in their offices here in New Haven are working on these problems right now. I'd be very interested, but certainly an active area of investigation. So in terms of things to take away from and things that you could do here on the wards today or tomorrow, begin by asking about depression. This is from the circulation article I showed earlier in 2008. They had this kind of complicated scheme over here. We'll get to this in a moment, but they settled on using the PHQ-2 followed by the PHQ-9. So this is a PHQ-2. So basically in the past 2 weeks, have you had little interest or pleasure doing things, or felt down, depressed, or hopeless? Some people will score this on a 0 to 3 scale. We just did a yes, no. If you answered yes to either question, then we considered it a positive. So here's the sensitivity and specificity of this. So it's a very sensitive screen for depression, but the specificity is relatively low. And so that guideline paper from 2008 recommends a two-stage screening process, following up with the 2-item PHQ-2 with a PHQ-9. And this is what we've done also in our research studies to confirm that we have people who truly are depressed. So here's the sensitivity and specificity of the PHQ-9. So in cardiac patients, you probably don't want to do the PHQ-9 first, because you're going to miss a lot of the patients. The sensitivity is only about half. But if it is positive, then because of the high specificity, then the person has elevated mood symptoms. So then the next question becomes, will treating depression improve cardiovascular outcomes? And if so, which ones? This is also, we had dinner last night with Kim Smolderen here from Yale. And this was a paper that she recently published looking at the TRIUMPH registry. And there's a suggestion that if you have depression and don't treat it, then you have significantly higher incidence of mortality after acute MI than if you do treat. Although this is not randomized trial data, and there's also concern that maybe the patients are different. Those who are treated might be at higher quality hospitals. They might be higher socioeconomic status. So, and a variety of other reasons. So it's hard. This is not a randomized trial to say for sure, but it's a clue that perhaps treating depression might make a difference on reducing mortality to that of people without depression. So these are a couple of the studies, and some of them Dr. Berg has been intimately involved with, like the ENRICH trial and COPE study. And so these are some of the brand name studies, randomized trials looking at treating depression. I didn't even include our work on there, but there's probably maybe another 8 or 9 studies like this, but I'll go over a couple of the major studies. So I mentioned Dr. Fraser Smith first, who had the initial highly cited paper. Well, she was funded in the 1990s in Canada to do a randomized trial of treating patients who survived acute MI in Montreal, and they were randomized to either a nurse-led intervention for psychologic distress. They would screen the patients each month after MI, and if they were psychologically distressed, they would make house visits and follow-up calls and so on. And here, this is very interesting. They found that there was no difference on mortality between the intervention or usual care, but women did worse. Women who were randomized to the intervention had higher mortality than those who were not. So that was really interesting. And why would that be? I don't know. I mean, maybe one thought is that since I've talked to Nancy about this, and she can't exactly explain why that happened. Maybe it's women don't like taking advice from other women. I'll show you later on also gender differences in treatment effects, but it's unclear, but it probably points to the need, if you're doing research, to power these trials on a two-sided p-value rather than one. This is the ENRICH trial, which at the time, and probably still is, the largest randomized trial ever done for treating depression in cardiac patients. This was stopped for futility. This was NHLBI funded trial. It was over $40 million, done at multiple sites around the country. And you can see over here, there was absolutely no difference in mortality between the intervention and usual care. And the intervention was treating for psychological distress. If you were very highly symptomatic, then people were getting sertraline, or Zoloft is a brand name. But there was absolutely no difference. People have published a number of studies looking at subset analyses, but in the intent to treat. There were also some issues, we could talk about this later, about the delivering the intervention. There was relatively, many people dropped out of the intervention. They didn't follow through. And that's certainly a concern when doing these large randomized trials. At the time the ENRICH trial was going on, Pfizer had funded the SAD Heart trial, which was using sertraline post-MI. And you can see over here, this was considered kind of a qualified success because of the composite endpoint had a trend toward a reduction in mortality, but there were other issues with this. as we know with antidepressants, no single antidepressant works for everybody. And any single SSRI, for example, might only be about 60 to 70% effective at treating depression. So often involves a combination of medications. Other issues here was the study was underpowered. They had a goal of about 600 people, and I think they got finished up with 379 or something. So this is considered a qualified success. Sandy Glassman followed up the survival of these patients for 7 years and found no difference in mortality. So that's also interesting to see. Would the treatment make a difference? Nothing. Chris O'Connor at Duke had a follow-up trial to that was SAD heart CHF, and this was using medications, also sertraline, in people with heart failure. No difference, not only in mood symptoms, which I'm showing here, but in the main outcomes paper, there was also no difference in survival from giving heart failure patients sertraline or placebo. Christine Engerman in Germany did another trial of heart failure patients using escitalopram, also known as Lexapro. Again, no difference in survival, just giving people a medication. So it's very different than like if you had done a beta blocker versus placebo or a statin or something else, ACE inhibitor. There's absolutely no difference here. So we know that treating depression is it's going to take more than just giving people a pill. So what are some of the limitations of what we'll call these conventional trials? As I mentioned before, there was a single antidepressant used in some of them. Patients' preferences for treatment were not incorporated. So they may have dropped out if they were randomized to medication, say, for example, if they didn't want to take medication, didn't want to participate in therapy. The screening and the intervention itself may not have been generalizable. How did people advertise for patients? Was it systematic screening, or were people responding to ads in a bus or something? Some of them had brief follow-up. So as I showed, like with the SAD heart trial, the initial follow-up period was only 6 months, few clinical events, low study power, and just generally lack generalizability, typical practice settings. So around this time in the late 1990s, by this time I was funded on a R01 to use a collaborative care trial to treat anxiety in primary care. So I was familiar with this kind of model. And the primary care model was developed in Seattle in the early mid 90s by Ed Wagner and others. And this was, we know in the United States that we're pretty good at treating acute issues like infectious diseases or surgical conditions and so on. But we don't do as physicians don't do, or healthcare systems don't do as good a job of treating chronic medical illness. And this could be heart failure, hypertension, COPD, as well as mental health concerns. So Dr. Wagner and others had developed this chronic care model that was linked to primary care. It uses a team approach where you have care managers who follow evidence-based guidelines and use registries to proactively follow up with patients between visits. So you're not just waiting for a patient to come into the office and so on. Using these registries, you might see somebody who's maybe non-adherent or has high blood pressure, high cholesterol, and then reaching out to those people and seeing how they're doing, and then also like connecting them to community supports, promoting self-care, getting leadership buy-in at an organization, and so on. And by the late 90s, early 00s, there was a sufficient evidence to show that this model worked in a variety of chronic conditions like heart failure and COPD and diabetes care. And people in Seattle and other places around the country, including Pittsburgh, were beginning to use this model to treat mental health conditions. But nobody yet had used this model to treat depression. So collaborative care in the depression realm, there have probably been over 80 trials that meta-analyses have looked at. The effect size improvement is considered small to medium at like 0.3. So not huge, but it was steady. Some trials had shown more, some had done less. But a couple of key things is that you can leverage the help of mental health specialists because they were kind of like coaching the care managers and providing specialty backup. So as a result, a psychiatrist could potentially consult on dozens of patients in an hour rather than seeing them one at a time. And it could also speed access to mental health care. So in our models, collaborative care, we were doing these over the phone, but in some of our recent studies, we've also done this over the internet. and using like the Epic systems. They call it My UPMC. I don't know if they have a similar term here, My Yale or something else maybe. To communicate with patients using chat and other secured messaging. More recently, collaborative care has become billable. So about 2 years ago, CMS had issued billing codes for collaborative care. So this has always been the challenge of how do you pay for the care manager? And in some systems, like where you have an integrated healthcare delivery system, like at VA or Kaiser or Intermountain, it may be easier to do than some places that are fee for service, where how do you bill for the care manager's time and the psychiatrist's time and so on. Our team has conducted over the last 20 years, our team has conducted 5 R01 clinical trials of collaborative care. All of them were positive trials. 2 of them, Bypassing the Blues and Hopeful Heart, we'll talk about a little bit more in depth. So we had a lot of experience of doing these kind of studies. So the first was the Bypassing the Blues trial. So I showed you that work before. I was in the room when people at the American Psychosomatic Society in 2002 in Barcelona, Sad Heart and Enrich both presented the main outcomes of their trials, and you could actually like feel the air come out of the room. Dr. Berg was there. I think probably the only other person in this room, but you could kind of feel the air come out of the room. There was a lot of hope and excitement for these studies, but it didn't turn out as hoped for. On a personal level, I had submitted an R01 to NHLBI after working about 3 years in the field, collecting pilot data, getting the experiences, as well as doing the anxiety trial. I submitted the grant, I think it was in June of 2001, and in the fall of 2001, it came back unscored. And of course, I was like, tremendously disappointed, and I came to the March 2002 meeting to hear the main outcomes of Enrich and Sad Heart, because I just had to be in the room to hear what happened rather than to hear secondhand. And I resubmitted our grant in June of 2002, and then it received a fundable score that fall. And I think part of the reason why is because the traditional models, the medication model, and the other kind of models that were used, counseling models, it was a negative trial. And I think NHLBI wanted to keep the field going and looking for a new model, and that was Bypassing the Blues. So at the time when I started giving this talk, it used to be over 600,000 bypass surgeries were performed in the United States annually. Now the numbers are down, I think, because of stenting and statins and better care and so on. But anyway, when you looked at CABG patients, whether it was pre-op or post-op, roughly a quarter of those patients met criteria for depression or elevated mood symptoms. And those patients tended to have delayed recovery from bypass, increased rate of readmission, cardiovascular events, and mortality. So the specific aims of the Bypassing the Blues trial was to see if collaborative care for depression could improve health-related quality of life, that was our primary outcome, physical functioning, mood symptoms, healthcare utilization, and healthcare costs. So it's quite ambitious. This was the basic study design. So this is from 2002. And before the work had come out with the PHQ, we had proposed doing the PHQ-2 screen in the hospital because we needed to get consent also. And then we would call patients up 2 weeks later. We didn't want to consider people depressed in the hospital after their bypass, because who wouldn't have tired or little energy or trouble sleeping if you just had your chest cracked open, right? So we waited until people got home and we rescreened them with a PHQ-9 2 weeks later, and then they were randomized to either the collaborative care for depression or to their doctor's usual care. And then the other innovative design that we had was a non-depressed comparison group, because we knew some of these patients would get readmitted, some would die, they would generate healthcare costs. So I thought also if this was a negative trial like some of the others I mentioned, that we would at least be able to compare the depressed and the non-depressed contemporaneously recruited comparison cohort. We were up and running in 7 Pittsburgh area hospitals. This was one of the posters that we used. It was also our first study to make a logo we're quite proud of. We had care managers. We hired nurse care managers who did the recruitment, and they also interacted with patients over the phone to assess treatment preferences, impart self-management skills, promote adherence, and adjust pharmacotherapy in response to the PHQ-9 scores, and also communicate with the primary care physicians, either by fax and telephone, depending on the urgency. We didn't give out any free samples of any medications. If we recommended an antidepressant, patients had to pay for it on their own. And if we couldn't get people well, we referred people to a community mental health professional. Pharmacotherapy is SSRIs largely, and then avoid to do harm, avoiding tricyclics and trying to get people off of benzos where we could. We had a weekly case review that the nurse care managers attended in a room like this, and we would project on the wall case registry screens like this one, and we would have a case discussion around the room with the study psychiatrist, Dr. Chip Reynolds, project coordinator, and myself and our study nurses. And you can see over here, like the collaborative care model talked about registries. This was our registry. So we could see the PHQ score over the time, medications, what the treatment recommendations were, and so on, and make appropriate recommendations. We told the primary care doctors, so this was the other innovation too. The other studies I showed, none of them involved a primary care physician or were kind of tied in. So how would you make this generalizable? So these were effectiveness trials where we sent PCPs our treatment recommendations. They knew which arm our study with their patients were in. We made recommendations for pharmacotherapy, but ultimately they were the ones to prescribe. So long story short, our nurses, roughly over a 3-year period, approached over 3,000 bypass patients. About 80% agreed to sign consent and completed the PHQ. Just over half screened positive, as kind of expected. And then you can see over here about a third of the patients, just under a third, scored 10 or above when we were able to telephone them 2 weeks after hospital discharge, and we randomized 302. Our goal was 300, and we did just above, as well as our non-depressed comparison cohort. I want to point out here we oversampled non-whites, and that's in the non-depressed group, and that's why there's a difference between the depressed and non-depressed by race, but it's largely the same. This is the main outcomes from the paper, our main outcomes paper we published a number of years ago. We saw an effect size improvement of 0.3. This is measured between the yellow intervention line and the usual care. So you can see even with treatment, we couldn't get people to the level of health-related quality of life as a non-depressed comparison group. That was the top line. So they certainly significantly improved. Beginning at 2 months, we saw an early and sustained improvement, but not to the level of the non-depressed, kind of pointing out that we may need better treatments for depression. Here's the other, looking at the mood symptoms. So you can see also significant improvements in mood. The non-depressed group is at the bottom. This is an impact by gender. Remember Dr. Fraser-Smith's MHEART trial that showed women did worse. Enriched, I believe, found the same thing where women tended to do, not as well. And here we could not say in the JAMA paper that women didn't do as well because confidence, the intervals overlapped, but you can see the effect size improvements were different between men and women. So it looked like men tended to do better than women by effects on the main measures over here. So this is part of our secondary analyses looking at readmissions. So you can see over here the pink line is very similar to the blue line or the non-depressed. There was a trend that intervention men, where the effect size was stronger, were less likely to be hospitalized. These are the number of care manager contacts. So you can see at 8 months, it was roughly a little bit more than a phone call a month, a little bit more, but it varied depending on how much engagement people were interested in. But the numbers between men and women that had similar numbers of calls. Pharmacotherapy. So you can see over here, roughly a quarter of the patients were on an antidepressant at baseline, and then it went up to about a little over 40% over time. But it wasn't like we were just throwing people on pills. You can see over here, look at 2 months, it's 36% in the usual care, and then kind of drop back. And that may be because of the screening and notification that we did. And so people started a medication, but didn't necessarily stay on it if they were randomized. But I don't think that we can attribute our improvement to just being, putting people on pills. So here was the other thing that we did. It took about 5 years to do this part of the study. And these were looking at the claims costs. We got Medicare claims, Blue Cross Blue Shield in Pittsburgh called Highmark, and UPMC health plan claims on roughly half of the patients, continuous claims. And you can see over here the cost differences between the two. It was not significant, but it was median. The intervention patients had a median of about $2,000 less. When we do these bootstrapping things, our study statisticians and healthcare economist Julie Donahoe did, you can see over here the incremental cost effectiveness ratio is about negative $10,000 per additional quality adjusted life year. So this is highly unusual. Most things we do in healthcare cost more to get better outcomes. I'll show you a second, some cardiology studies. But you can see also here, repeating the study statistically about 1,000 times, we show that it's most likely cost reducing and quality increasing where it falls in that bottom right quadrant. So putting this into perspective with other studies, nearly negative 10,000 is really just incredible. And there are only a few things in healthcare that we do have a negative quality adjusted life years, like prenatal care and a couple of vaccines. Not much else. And you can see at the top half of this slide are the costs, and maybe these costs should be higher these days, but it's probably still relatively similar. It's highly cost effective if you use the $20,000 standard of highly cost effective interventions, but 50,000 is more typical, and some people have talked about moving up to 75,000 because of healthcare inflation. But certainly, treating depression alone is highly cost effective. But if we put this in perspective of things cardiologists and primary care doctors routinely do, like screening lipids in middle-aged men, treating type 2 diabetes, I mean, it looks like a bargain. This is some long-time follow-up. One of the medical residents working with us presented these analyses at the ACC a couple of years ago. And you can see over here, there was a significant increase in the depressed versus non-depressed patients, even after adjustment over time. So it's kind of similar to Ingrid Connery's work that I showed earlier, but we did not find any differences by treatment assignment. That is, the intervention people in our Bypassing the Blues trial did not have lower mortality than the usual care patients. Nor did we see anything different. This is in men where we had the strongest effect size, but we didn't see any differences in either the overall or in women. So final things to kind of come out of Bypassing the Blues is that this telephone delivered collaborative care could improve health-related quality of life. That was our primary outcome. Improve physical function, reduced mood symptoms. It also reduced post-CABG pain, which was in a secondary article by Natalia Marone, and also reduced healthcare costs, or trend was highly cost effective. So I always feel like, there's so many papers that come out every week in the literature, and I was looking at the email Dr. Berg sent me last night of all the papers that just came out of Yale Cardiology this past week. It's a very impressive number, but I always feel that too many studies just sit on the shelf and people don't read them. So I really think about what can we do to kind of get our work out there and that people use it. I'm really delighted that our work was also cited in other scientific statements from American Heart Association. And also going back in 2014, we had a colleague in thoracic surgery at University of Pittsburgh who since moved on to University of West Virginia, but he was involved with the SDS. And now depression is one of the things that are abstracted in the STS data set. So maybe, you know, there's a young Bruce Rollman out there who's going to look at this someday and repeat those analyses and this time have depression as a covariate. We were also mentioned and cited in other scientific statements too about secondary prevention of after bypass surgery. So I mean, this is like, you really want to see your work get out there and kind of get promoted. It's a big deal when we get like a random email from some other researchers who want our data to include it in a meta-analysis or something. It really is important as a way of getting your work out there and hopefully making a difference. We also teamed with UPMC Health Plan. We did a couple of years back, we did a depression initiative with their care managers where we trained them on a checklist, A, B, C, C, D, E, F, F. And very simply, we trained the health plan's care managers when they call patients up after MI and went home to screen for these kind of things. I got the idea from Atul Gawande's checklist book. And over time, it wasn't a randomized trial, but the health plan found that in the first year, it saved nearly $4 million of costs. So going back to that other question, will depression treatment improve cardiovascular outcomes? We never really answered it with any of the studies, you know, that we did, I did, or presented. So our work started to move in the mid-00s to heart failure. You know, at the time I was interested in bypass because you knew when someone had a bypass surgery and you could pursue depression afterwards. But heart failure to me was always kind of a vague condition. There was no like starting date. There might be at a hospital admission date, but there was no formal starting date. And also, like, were we going with preserved ejection fraction? Were we going with reduced ejection fraction? A lot of people, when I attend on the inpatient service, were labeled with heart failure, but they didn't actually have heart failure. Maybe they had diastolic dysfunction, maybe they had COPD, but they didn't have it. So my attention started turning to this in the mid-late 00s, and we did the pilot work that led to our Hopeful Heart trial that was published last year. So similar to depression and other cardiac conditions, very prevalent in heart failure patients. And I was also really, really intrigued because heart failure was while it was growing in incidence, unlike bypass, which was coming down, survival hadn't much changed. There were small changes in survival over the last 10, 15 years, but it was not dramatic like post-MI survival, post-CABG survival, and so on. So there was still a relatively high rate of mortality that you could do one of these, you know, randomized trials that you didn't need thousands and thousands of people to show mortality differences if they existed. So my thinking was, what if we can apply collaborative care to heart failure care? So that led to Hopeful Heart, but Hopeful Heart also had some other innovations too. My late colleague, Wayne Caton at University of Washington, Seattle, had presented some really nice, or not presented, he led some really elegant collaborative care trials in the 00s. This one, the Pathways trial, was treating depression in patients with diabetes. And he found over here that it did not make a difference on the A1C. It was a small improvement on mood symptoms in this trial. It was like 0.2, 0.21, but there was no difference on A1C. And he followed it up also with what was called the Team Care trial. And the Team Care was the first blended collaborative care trial. And in this case, the blend was depression and also diabetes care. And he found that they could train up a nurse to do all this together. They had a roughly like a point drop in A1C, systolic blood pressure, and LDL cholesterol all significantly dropped, as well as the mood symptoms. Mood symptom improvements, I think, was like a 0.67, which considered a moderate to large effect size improvement. Really, really wonderful results. They were published in New England Journal about 12 years ago. They've been cited now over 1,000 times. I mean, this is another landmark paper. But the idea was, and one of the things I didn't like about our bypass study is that we just focused on the depression. How could that be implemented? Or were we calling for a separate siloed, another team of care managers to do the mental health care? Could we train up a single nurse care manager to do heart failure care as well as depression care. And that was really one of the other innovations in Hopeful Heart, was blended collaborative care for depression and heart failure. So we had similar aims as in bypassing the blues, a similar design, but this time it was another innovation I learned from another colleague at APS. Dr. Ken Friedland had published an influential article on control groups in behavioral health trials. And Dr. Friedland had talked about the control, having the need to have a potent attention control group. So in many of our other studies, so these 80 trials of collaborative care, including my own, had always used a usual care comparison group, not a true attention control. So unlike team care didn't have this either. So they didn't have a separate arm that was just diabetes care management. You know, it was the blend versus usual care. Hopeful Heart had a third arm that people were randomized to, and that was collaborative care for the heart failure alone. So we wanted to have a potent attention control group as well as the blended, and we retained a usual care control group so that we could compare to other collaborative care arms. Sounds a little complicated, but I'll show you the results over here. So also over roughly a 3-year period, our nurses approached nearly 12,000 patients. You can see here, roughly half screen positive in the hospital where we got signed consent, and roughly a third screen positive on the PHQ-9 about 2 weeks after they got home. Again, we didn't want to call people depressed in the hospital because if you had heart failure, you might be having trouble sleeping, low energy, and we didn't want to confuse that. Here are the sociodemographics. Again, a slight difference in race because of oversampling. But the other thing I want to point out that's really key, look at the ejection fraction. These were all patients who had an EF of 45% or lower to be eligible for the trial. But the depressed and non-depressed, you can't attribute, other studies have reported this too, you can't attribute the low mood to a low ejection fraction. That's the point I'd like to make here. And the rates of comorbidities, diabetes, hypertension, post-MI were similar between the depressed and non-depressed. As expected, you know, mood, health-related quality of function, and function were lower, but these were self-reported. Look at New York Heart Association class 3 and class 4. So people self-reported their health is worse if they were depressed. And I think that's really important for cardiologists to recognize. It wasn't the ejection fraction. It wasn't the comorbidities. It was the comorbid depression. So similar 12-month intervention. Here we had the blended, similar case reviews, weekly case reviews, but I'll cut out because the hour is late to the main outcomes. This is what we reported. The very top line over here is a non-depressed comparison group. And our primary outcome measure over here was the SF-12 MCS, or mental health composite score. And there was again, a significant improvement in the blended versus the usual care. But you can see the EUC or collaborative care for heart failure alone and the blended were very similar. Those are these middle two lines. These were the point differences by gender. Again, we powered our trial by to look at within gender differences because of our earlier work and MHeart and Enriched and others. So we could see over here blended versus usual care. In this case, it looks like women did better. In bypassing the blues, there were trends that men did better. These are the effect size, the forest plots of the effect size differences. Again, the main outcome measure was the SF-12 MCS. And but there were not any differences you can see in the Kansas City cardiomyopathy questionnaire or the SF-12 physical function. When we looked at mood symptoms, we found significant improvements in the blended over enhanced usual care, which is the other thing that was really important to show that collaborative care for depression is really more than just calling people on the phone and seeing how they're doing, you know, because the blended arm had a significantly improved effect size improvement of mood symptoms over the collaborative care for heart failure alone. So we knew our intervention was doing something. And again, this was something that No other collaborative care trial had this kind of potent attention control. Readmissions, to date, we didn't find any differences. We're still extending this follow-up as well as for mortality, but there were no differences either by baseline depression status. Roughly about 80% of people were hospitalized. It's extremely high rate. We also presented in the E appendix data looking at the per person per month rehospitalization rates, because some people were hospitalized multiple times, and a Kaplan-Meier fails to capture that. Again, there were no differences either by baseline depression status or treatment assignment. Same with mortality. So we are continuing to follow up the mortality. I'm working with a fellow back at the University of Pittsburgh, and we hope to present the 5-year mortality rates. The other thing that's very new, we just submitted this week to present at a Society for General Internal Medicine this year. We got the insurance claims. This time we did it in 3 years, and we got the Medicare, the UPMC health plan, and the Highmark Blue Cross Blue Shield. This roughly on 80% of the patients who were involved in the trial. These are, you can see the mean and median costs for outpatient. Inpatient is really dominating the costs over here, and you can see the totals. The trends are in the right direction, but we're still analyzing the data. These are typically, you see claims costs being highly skewed, and we had a couple, the top 1% of people were over $2.7 million in the 12 months after index admission for heart failure. Now, why are they so expensive? We found roughly about 12 people had heart transplants. There were LVADs, and there were other things. So we think that, you know, we need to look at the data a little more, cost data a little more carefully, because treating depression probably isn't going to make a difference on whether or not you get on the transplant list and so on. So stay tuned. I'm also really pleased, and I'll give a shout out to Matt, who's involved, Matt Berg, who's involved in these trials. There are 2 European replication trials going on right now, and working with colleagues over there. Kristen Herman Lingen, who also is an APS former president. He's leading the TEACH trial and the ESCAPE trial. He's involved with the team on ESCAPE, which is a multinational European trial looking at blended collaborative care for people with multiple cardiac conditions, and the other was for people with heart failure. So it'll be interesting to see, and also what the results are in a different healthcare system. And this is, I guess, we're a few years from hearing that. So kind of summarized this morning's talk, depression is prevalent and predictive of poorer outcomes for patients with cardiovascular disease. Treatment will improve quality of life, mood, and pain, and it's highly cost effective, but it's unclear if treatment actually reduces cardiovascular morbidity and mortality. People have proposed really large studies, like in the thousands, but these are like, you know, tens of millions of dollars to do these studies now. I don't know if they'll ever get done. Maybe it might just be meta-analyses, but that's no reason not to treat, to screen for and to treat depression in your cardiac patients. We do a lot of things in healthcare, like back surgery and shoulder surgery, cataract surgery, you know, that probably doesn't do anything to prolong life, but it's expensive and definitely improves quality of life. So I think we need to think about that. And as a cardiologist too, if your patients are coming in with heart failure symptoms and you're providing the best evidence-based guidelines, but they're still really symptomatic, you know, don't wait for depression to be considered as a diagnosis of exclusion after everything else is worked out. It's really common, and maybe it's, for those patients in particular, it's really important to screen for depression who are still symptomatic despite your best efforts and objective measures like ejection fraction, echocardiograms, cardiac caths, and so on. So, you know, please do consider depression as part of the treatment. But still, I would say that more effective treatments are needed. So I showed you the checklist, and part of the checklist was E for exercise or cardiac rehab. I think cardiac rehab in most places have done a really good job in recognizing the impact of depression. And also because of the exercise is another effective treatment that you could do. Not everyone needs a pill. And for people with just mild symptoms, it might be just, counseling and exercise makes a difference. I kind of wanted to summarize this. I showed you this slide earlier from the 2008 Lichtenstein paper. But basically, if you could just remember this, screen your patients with the PHQ-2, down, depressed or hopeless, tired or little energy most days over the past 2 weeks. If they say yes to one of those, then consider the PHQ-9. If you can't find the PHQ-9, just go Google PHQ-9 PDF, and there are a lot of beautifully formatted PDFs of the PHQ-9 that you can administer. If the score is less than a 10, you could just stop. Okay, so I showed you the sensitivity and specificity. So with this kind of two-step method, if it's less than 10, you could just stop. If it's 10 to 14, then it could be watchful waiting, or maybe consider treatment if the patient had a prior history of depression. So maybe they were depressed 5 years ago or something, but if they never had depression in their lives, then it might be just something to reevaluate or put in your consult note to the primary care physician, or recommend cardiac rehab or something else to stay physically active. But if it's over 15, that's considered a moderate to high score. Then I think it would be key to be treatment. And you might want to talk about medications, chiefly SSRIs and SNRIs, or bupropion, counseling. Maybe if people have complicated psychosocial issues, maybe they should see a mental health specialist. And of course, exercise, which is generally always a good deal to recommend in cardiac patients. I just also wanted to say thank you. This was our research team when we're at the peak of doing Hopeful Heart, as well as the online treatment trial for mood and anxiety. None of our work in Pittsburgh, none of this would have been possible without having a terrific team. And in the middle is Dr. B. Belknap, who's involved with the TEACH trial and that's going on right now in Europe. And come to our website to see more. Thank you very much.
Questions?
So Bruce, thank you for a great talk. I guess my question is, having been kind of following this field for some time and being involved with some people out, some people you mentioned along the way, my time to do. I've always been struck by the fact that it was very hard to define a dose response, so to speak, of treatment per se. And I wonder if you can elaborate on whether you think that relates to the fact that depression treatment in general, as you said, should be tailored. It's not necessarily going to be, it's not going to reduce depression in all people in equal amounts. So I mean, how do you integrate that information into further studies of depression, management?
Sure. Well, some of it is also like what patients are willing to do. So, cardiac patients may be on 7 to 10 medications or more, and they don't want to take a pill. And that's okay. Certainly my patients with cardiac disease, I try to twist their arm for a statin if they'll take it and tolerate it, or an ACE inhibitor or something. But not everyone, wants a medication or will benefit from medication. But chiefly like exercise, socialization, really kind of like just basic things. Counseling, if they're willing to do that. I think there's also new options that have opened up with telehealth, that they can get access to a mental health counselor, but they have to really want it. And I think also to see where people are in their condition. Eric, so some of the other things I do, like if I have a diabetic patient with peripheral neuropathy, then I might think about like duloxetine or something like that has FDA approval for peripheral neuropathy and also fibromyalgia. So I try to work with people, based on what are the indications for a medication, but really just seeing where they are. Some people are difficult, and you're not going to get them to respond, and they don't want to see a mental health specialist. It's definitely a challenge.
Picking up on Eric's question, I go back to one of your early slides which was about mechanisms. And, in our trials, we were focusing on depression, in RIDS, et cetera, in all of those. And then the more recent trials, the collaborative care model, the blended collaborative care, are really focusing on some of the factors that are associated with depression. So it's not just that here's this patient who has smoking morbidity and that includes depression, but they're having difficulty managing their smoking morbidity. And so part of what collaborative care does is it supports them in that management. And so that addresses some of the behavioral factors that are associated with depression. And it may be that focusing there really starts to move the needle. And by relieving the patient of some of that burden can affect depression. The other thing is, the signal with women in Montreal and in Enriched, a follow-up analysis in the Montreal study revealed that among women, those who responded to the treatment within the first 2 weeks had better survival than any other group in the trial. Now, of course, it's a secondary analysis. It's not a pre-planned analysis, but it speaks to, if you're going to do a treatment, you better be targeting what is the operative variable. And if you're not, you can actually make matters worse. So if there are these distressed women and nurses showing up and the nurse is not being helpful, one can imagine that they are more distressed after the nurse leaves because they were counting on the nurse to help them. And that then also reminds me of the work of Theo Vaccarino looking at male stress-provoked ischemia, where they're seeing these younger, within the distribution of patients post-MI, the women are younger and are more likely to have social determinants of health, living in poverty, abusive relationships, and things of that kind. And it makes me wonder whether the depressed women who are coming into our trials are also part of what's driving that depression. Are these other factors that it's like, I've got this horrific situation at home and you're trying to treat my depression?
Yeah, stay with that idea. That's actually, and Chris Callahan wrote a really nice editorial to our Hopeful Heart main outcomes paper. And it's where also my work has been going also in recent years, thinking about these social determinants. So I see patients in our clinic and there's a lot of, we hear about it, but there's a lot of income inequality. There's a lot of people who can't afford these medications, or especially if they have diabetes and some of the newer, GLP-1s, SGLT2s, and whatever that are on patent right now. And we had this also in our case discussions when we would talk to patients, on our case reviews, not talk directly, but care managers would say they can't afford this, they can't afford the copays to go to, or the transportation, or take time off to go to cardiac rehab. So, I mean, these are big issues. We know cardiac rehab works, and or eating healthy. What's eating healthy for you or for me? So these are really, really big issues. I think this is going to be, I see in the Biden administration is trying to address some of these issues. Last year, they had the child support payments and others. I see it also in value-based health designs where you might have copays waived, if you're getting a statin or something. But I think this is going to be a big issue. I'm really curious in part to see how I'm curious about how the European trials turn out. But in Europe, they tend to have less income inequality issues than we have in the United States. So it's going to be really interesting to see how those studies work out. I think we were somewhat limited, because of people couldn't afford their meds or couldn't take. We freely recommended cardiac rehab or other things, but they couldn't take time off from work. And these get into beyond our work as a clinician. We're in this box, but now these are bigger societal things where policy changes need to be done. If we're to maximize the potential benefits from our effective treatments.
Thank you. Thanks so much for joining us. I'm sure if people have questions, they can reach out to Matt and get in touch with Rollman. And sorry we didn't have a better showing here. There was a lot of people online, and I checked. So thanks everyone for joining.
Thank you for inviting me.